So maybe we can already start with a few welcoming words, and then slowly let more people in. Very pleased to see the many participants coming from many different parts of the world. Don't hesitate when you have your name indicated in the participants list that you also indicate where you are from. So behind your name, comma, and then the country. It's always very interesting to see also the different interests that we see from around the world. So a very warm welcome to this webinar today. My name is Ili Dwandland. I'm the Secretary General of the International Association of Universities, an international non-governmental organization that was created and called into life by UNESCO a little over 70 years ago to actually facilitate cooperation and networking around higher education institutions around the world post-Second World War, to build peace in the minds of people through collaboration, networking, exchanging, learning from each other in a different way. And so in the minds and spirit of the very initial mission and vision of the International Association of Universities, when Agenda 2030 was adopted, we thought that what could we do best as an association with global perspective? It is to create a global higher education for sustainable development cluster of universities, bringing the universities of the world together to learn from each other, but also to showcase how they engage with sustainable development, what it means at institutional level, and how a university then engages the many stakeholders inside and outside the university. So the IAU Global Cluster for Higher Education and Research for Sustainable Development was launched in 2018. And it brought together initially 17 lead institutions to lead on the 17 SDGs, SDG 17 partnerships being led by the International Association of Universities. And when exchanging and contacting UOC, the Open University Catalonia, it became very easily obvious that you as an Open University Catalonia specializing in e-health and health issues in general, that you would be able to lead on SDG 3, and that's what you do brilliantly now ever since. Each of the cluster leads in the global cluster were invited to then bring in universities from around the world, because the idea is really to have this networking of knowledge dynamics from different parts of the world in recognition of the importance of diversity and mobility of thought. So you brought together a very dynamic group of members from different parts of the world, and these institutions I will name because it's interesting to learn how these kinds of cooperation can actually lead to innovation, transformation, sharing of ideas in a very proactive way. So the University of Catalonia is based in Spain, Catalonia in Spain. And you lead on the work and have undertaken quite a bit of work, and you can find more information online. You partner with the Universidad de Caldas in Colombia, and then the University College Dublin in Ireland, Universitas Gajah Mada in Indonesia, Karolinska Institute in Sweden, University of Public Health at Makerere in Uganda, and Western Sydney University in Australia. So you see that this is really a unique connection of like-minded people from very different horizons from around the world. So we're very warm welcome here to the co-hosts, UOC, and the organizers of the event, and as well to the many speakers from these very different horizons already. So this topic of gender and health in higher education and research context is absolutely key. We've seen it come up post-pandemic, but not only, it was important before, but it gained new momentum. And it will be very interesting to see how the different speakers address the issues that are pertaining to gender, to equity, to inclusion, but specifically related to the topic of health. So I'm very actually honored to have been invited to open this webinar, and very pleased now to give the floor to the moderator, Gemma Mafani, who will introduce the speakers and launch what is promising already a very nice conversation and exchange about the various topics pertaining to the topic of this webinar. So a very warm welcome. The floor is yours, Gemma.
Thank you for this introduction. I'm already, what I want to say is hello to everyone here. I hope that this is going to be a very lively debate, and many of the questions that are going to be now discussed here are really relevant topics. So first of all, let me remind all of you that you are very welcome to make any question that may arise. Please use the question and answer button in your screen to just send these questions, and at the end of the debate and the roundtables, then we are going to pose the questions to our speakers. Let me introduce myself. I'm Gemma Marfany. I'm a professor of genetics at the University of Barcelona. And so this is not exactly my field, but actually think that's not the point. The point is everyone that are here in this room is because it is really involved in health, in improving the health in future, and e-health is there to really tackle and to deal with. So I'm going just to make a very type of provocative questions at the beginning. Everyone is aware that health is a right, and we should all of us have access to health. But how can we promote, how we can favor this access to health? And countries now are very big, population is dispersed. It's very difficult that many people have access to central hospitals or even to have just contact with medical doctors or nurses. So e-health now is, it appears to be a very good solution. But I think we have to ponder many other things. So indeed, if you are using e-health, it means that you have web connectivity, you have access to internet, you have access to mobile phones, computers. We have to know if this is right for everyone, or maybe we are, instead of improving equity and access to health, maybe what we are doing is just that poor people are still poorer because they don't have access even to e-health. That's one of the questions, but there are many others. Who has this kind of access? Is this helping women that are usually at home in many countries, or that they are on the other side, maybe they are really working hard? Do they have access to this e-health? Who is having this access? Is in countries where there are many different languages spoken, is this a barrier when these people in need to ask questions, in need to receive this input, are they really being offered what they need, or this is more a barrier than a help? So in one hand, we see the future and where we wish to tend to, but on the other hand, we have to be aware of pitfalls and situations that we need to deal with. And this is why we have this wonderful panel of speakers. All of them are very, very specific of their area, and I'm going to introduce one by one all of them so that they can also introduce themselves and how they are approaching all these issues. So maybe what I will do is just one by one name you and just give you the floor so that you can introduce yourself and so that I can go on with the rest of you. And I'm going to start with Redna Siwi. She is from the Faculty of Medicine, Public Health and Nursing from the Universitas of Gadjah Mada in Indonesia. Please, Siwi, just introduce yourself to all the rest.
Thank you, Gemma. It is my honor to be invited in this network and in the very important and interesting webinar. I'm Ratna Siwi Padmawati, or just call me Siwi. I'm an anthropologist now working as a lecturer and researcher at the Department of Health Behavior, Environment and Social Medicine in the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta, Indonesia. My works are mostly on public health, health policy and health promotion and education, with varied themes, such as on the health-seeking behavior, stigma among people with HIV and injecting drug user, tobacco control, and TB, and so on. So in this opportunity, I would like to speak about culture, gender, and equity in Indonesian cases. Thank you very much.
Thanks, Siwi. So we are going to move to the following speaker so that she can introduce herself. So Dr. Lydia Arroyo, she's a sociologist and she is a researcher of gender and ICT research at the UOC at the University of Catalonia. Please, you can introduce yourself, please.
Okay, thank you. Thank you, Gemma. I am Lydia Arroyo, and I am sociologist. Then my approach to health issues is from social science, from a gender perspective specifically, and with an intersectional approach. Concretely, we have a study about data, COVID, and gender, in which we analyze the incidence of COVID-19, taking into account the labor position of women and men, and taking into account also the vertical segregation that it's related to social class and level of studies.
Thank you. Then we are going to move to the next speaker, who is Dr. Eduardo Bichitero, Senior Technical Officer of Data Science and Informatics at Monitoring and Evaluation Technical Support Program. He is from the Makerere University in Uganda. Please, you may introduce yourself.
Thank you, Gemma. I am a computer scientist by origin who sort of wandered sideways into public health. At the METS program, we're under the School of Public Health within the College of Health Sciences of the university. But we're very much the implementation arm and the more operational research side of things. We provide assistance to the Ministry of Health and as well to other health partners that are invested in the Ugandan public health space. Specifically in my area is data science informatics. We do computerization, we do data collection, we do analysis tools, all to help speed the collection and basic analysis of public health data. Thank you.
Thank you. And now we are moving to the last of our speakers. So Dr. Hannah Dahlen, she's professor of midwifery and associate dean research from the University of West Sydney in Australia. Please, Hannah.
Hello, good evening from Sydney. I know it's all different times of the day around the world. My name is Hannah Dahlen. I'm professor of midwifery. I have my main interest at the moment has been leading one of the largest studies on COVID in Australia. We're doing a big longitudinal study following women and babies up who have been pregnant or given birth in the pandemic at 2 months, 6 months, 12 months, and now 24 months afterwards. A lot of my research is around human rights, birth trauma, access to care, women who avoid care, what are the underpinning reasons that occurs. And I'm very proud to work at Western Sydney because we ranked first in the world this year in the Times Higher Education Impact SDG rankings, which is a very exciting thing for us. And also we're third in the world for gender equity. And of course, that's a key topic of this webinar. Thanks.
Thank you. Thank you, all of you. So now that I think that all of the audience can know where you come from, what you are working with, how you focus on these issues in your own work, I think we can move on more specific questions. For instance, I think that some of the questions that are now on the table is how cultural and gender issues are managed in health. If we have more access now, but this leads to more inequity, for instance, if now with pandemics we have more problems to access to this health, how this has improved or not, and then how we can improve this general access for everyone. So I think that we can start with this roundtable, and probably the people that should now speak is Redna Siwi and Lidia Arroyo and Eduardo Bichitero. So Redna, Siwi, if you wish, you can start with, so that we can just debate a bit on these gender and cultural issues and health.
Okay, thank you very much again, Gemma. Yeah, as known, the outcome of health of the community is influenced by socio-ecological factors ranging from internal and external factors of individuals, families, and communities, as well as the health system and related sectors and government policies and actions. To be working nicely and ensure equity to all, the interrelated sectors must give equal opportunity of health to all population groups, and especially to those disadvantages. And resources are distributed and processed are designed in ways that will benefit or improve the health of all, especially those who are vulnerable. So, although the involvement of women in income generating activities have been prevalent and tend to increase, the burden of domestic chores has not been decreased, or on the contrary, tend to be doubled. Yeah. Domination of husband, this is in the case of Indonesia especially, is existed and already embedded in the society. In practice, the power relations are all negotiated between women or among women with their environment, including their husband, families, and their culture. And this is somewhat difficult to be solved, say in Indonesia, even in highly educated women. Yeah. The difference of social roles carried out by men and women have impact in their health behavior. There are roles, behaviors, activities, and attributes that society considers appropriate for men and women. And to mention only a few, the attributes of women as a non-decision maker, usually in the family, but they are a gatekeeper of the family, family health and welfare, and they attend to domestic chores rather than outside activities. Although this is classic and traditional, maybe they can say, and not relevant maybe in the younger population, but this cause unfair gender relation. So this is on the contrary, as for husband as breadwinner, they are seen as a central figure, dominant, superior, and become the sole decision makers in the family. So some practices have been done in Indonesia, but many also that resulting unfair gender relation. Yeah. For instance, the belief about the pregnancy as a fragile period of for women, so that they should be protected and carefully taken care of. And this is also, there are also belief and practices that do not benefit a woman or even pose risk to them. Yeah. In the practice of, for instance, one culture that is in some part of Indonesia, like giving dowry from the grooms to the bride family that are very expensive, causing them to take a loan. Thus, the newlywed will suffer from paying their debt in expense of their own needs. This is only an example. But then also in the another case, because the gap between the age group, especially I'm talking about the older generation, in case of the patient with the patient is the matriarch in the family, this woman do not prioritize getting treatment they needed due to domestic responsibilities such as taking care of the children, cook for them, clean the house, etc. So they would feel selfish if their needs come in the way before their families. Thus, the delay in seeking proper management oftentimes get longer. This is also the case with COVID cases. Yeah, some women they hide the symptoms and so on and so forth, and then they only deem disease because of their disease, and they feel irresponsible for putting their needs before the family. Yeah, so in cases such as HIV and IDU cases or injecting drug user, women are expected to have appropriate behavior. So becoming an IDU or living with HIV would cause women experience self-stigma. Thus, access to ARV and methadone is often limited. So these practices are structured and deeply embedded in the society, even though there are so many informations by the government, especially during COVID, but there are so many also information that is not true, or people then getting confused with the informations. Yeah, and the application help in the form of, for instance, e-health, it used only for the younger generation. So I think this is only a short description about what is happening in Indonesia, and especially in that is now in the situation, especially in COVID and before COVID. So yeah, I think we need to recognize what has been done in this condition, and we should have a better equipment or to intervene. Thank you very much. I hope this.
Thanks. No, I understand. I think that you just put on top of the table that there are differences in culture, and also as you say, the role of the women in different cultures, what they are expected. I mean, you have to meet the expectations, and then health is just the last of the priorities, and this is, I think, increasing the gender gap. I think Lydia has something to tell us about this gender gap and how the COVID pandemics maybe has even influenced this. So Lydia, what can you add to that?
In relation also the digital divide, I think it's important also to look into the uses of the internet. And when we look for the statistics on which kind of use women and men do on the internet, we find that the main difference is in health issues, to look for information on internet in health issues, and to read newspaper online. And we had that women look more information for health, and men no, and men reading more newspaper online, and women less. No, and I think this data is very interesting in terms of how the norms that Redna said, the gender norms are interiorized inside the subjectivities of men and women, and reproduce this on the use of the internet. And these elements show two important issues. One is which kind of health information they find, and I think it's important the quality of information, of health information that we find all together on the internet, because when we analyze the intersection of gender and social class, in the case of the level of studies, we find that the less people of low level of studies look for health issues information on the internet. And when we analyze this qualitative, in a qualitative study that I made, women from the low level of education find the confidence of this information, like if they feel that this information is true, no? An internal feeling, an emotion. And on the other hand, the women with higher education, we look into the source of this information, and then no, it's not only a feeling, but also the importance of the source of the information. And I think it's important to take into account the gender and also the social class. And in terms of gender, another issue related to what Rena was explaining is about how women take care about herself more than men, no? And it is also a gender socialization norm, but also they take care from others in the house, because these statistics that we see that women look more information on health on the internet than men, it's not only for them, it's for her children, her husband, her mothers, fathers. And it's important also to take into account, as Rena said, the double work that women have with a lot of mental and issues for mental health of women. And in terms also of how social inequalities and gender inequalities have an impact of the health of women. And women, we know that live for more years than men, but the quality of life it's worse. And I think it's important also to identify how social and gender inequalities affects to the health of the women.
I think that this also depends on the society you are living in. So here, for instance, in Europe, women and men have, all of them, access to internet, and they can have this information, but maybe not all over the world people has this access to information or even access to internet. So I don't know in Uganda, Edward, what do you think? Everyone has access or equal access to this information, or this not equity in access adds to the inequity in health, or how do you foresee this?
I mean, absolutely, the infrastructure requirements for accessing e-health really do end up deepening the digital divide and the gender differences in accessing this information. Firstly, as you said, cheap internet access, the sort of unlimited internet plans that are found in Western Europe, in the Americas, and actually in several parts of Southeast Asia, are rarely available here in Africa, especially in sub-Saharan Africa. You have places where essentially there's one family phone. So if you're doing any sort of mobile health outreach activities, the phone will essentially be owned by the head of the household, typically the man, and whatever access you need for his wife to have will have to be mediated through that factor. Even when it's a bit more, there's more of a digital access in the family, the internet access tends to be prioritized towards the main earner, who is probably also has work-related activities, email, whatever, and also the children who are growing up in a little more activated state. So that does really end up really exacerbating the gender issues in society. Thankfully, in our context, because of reproductive health, the female members of the household tend to visit health facilities more often. But that also gets offset by the other problems they face. But particularly in e-health, there is a danger sometimes of e-health provides the opportunity to reduce costs in providing access to patients or visibility to patients. But there's also danger where you end up outsourcing the costs of access to the patients themselves by having them to have these digital devices, having them to pay for bandwidth of internet or access different services. And that in the resource constrained context of sub-Saharan Africa, and particularly Uganda, that becomes especially important. Thank you.
Yeah. I think now that we have the context of very different context in Indonesia or in, as you say, in the Western countries or in Africa, so the context is different. But I think that you just said something that is relevant, and is that because of maternity, women in Africa tend to visit more health centers, or at least to be worried about that. And I think that, Hannah, you're a specialist on that, because being a midwife and professor of midwifery, and how you see if this, how you envision if this worry about maternal health, if this is adding to inequity or not, or it's a path that we could use to arrive to women and to provide health for everyone. How you envision this?
Yeah, look, I think that the COVID-19 pandemic's turned a very bright spotlight on the nexus between gender equity and health. And some are even calling this the emergence of the next wave of feminism as a result, that we've seen that actually all of the issues that we've known for many, many, many years and centuries are well and truly still there. And if you look over the last couple of years, the last 2.5 years, women have been the carers of everyone. They've homeschooled their children while trying to do their jobs. They've lost their jobs in higher numbers because they often are in more vulnerable jobs or in hospitality jobs, etc., which were more affected during COVID. They've cared for elderly relatives. They've experienced increased domestic violence because they are locked away with their abusers without those usual supports during the pandemic. They've experienced worse mental health. You have to look at female academics to realize that publications have declined, and while that looks like it's evening out, are women trying to kill themselves to pretty much stay equal? And then if you look at racial differences, we see this even more clearly. We've got white mothers and black females, regardless of whether they're mothers or not, taking the strongest hit when it comes to academia and to economics. In 2020, I published a paper with 2 lawyers, and it was entitled "How COVID-19 Highlights an Ongoing Pandemic of Neglect and Oppression When It Comes to Women's Reproductive Rights." And we found that this was most clearly seen in the provision of abortion services and in maternity care in Australia and internationally. We saw those services having supplies cut or being called non-essential. We had them having to scrabble around to try and find personal protective equipment. We saw contraceptive supplies declining. In the maternity space, we saw more and more women moving towards home birth as an option to ensure that they had their partner and family with them. And at the very same time, midwives who were providing those services could themselves not access personal protective equipment. A survey we did of privately practicing midwives in Australia in 2021 showed midwives were having to make their own masks, their own hand cleanser, at the same time that 93% of them were showing an increase in women wanting to actually give birth at home. We had birth centres shut down and turned into COVID clinics. And in countries like the UK in particular, we saw home birth services decline just as women were more likely to want to seek this option. And the result was we saw more and more free birth. So we had this sort of perfect storm that was brewing. And if you look at the Guttmacher Institute report, a really worrying report where they looked at 132 low and middle income countries, and they estimated that even with a modest 10% decline in access to care in those countries, that there'd be an extra 15 million unintended pregnancies, leading to unsafe abortions, leading to 1,000 extra maternal deaths, and an extra 1.7 million women and 2.6 million newborns experiencing major complications. And this would potentially lead to another 28,000 maternal deaths and 168,000 newborn deaths. And this is really shocking, and it led to the Lancet Global Health publishing a really astute paper. And they warned during the COVID pandemic that maintaining reproductive health care was not a luxury, but it was a matter of life and death. And I think so often women's health is seen this way. It's seen as a luxury. It's seen not as a matter of life and death. And so I would say we saw women left holding the baby during the pandemic, and it's come with deadly consequences in some parts of the world. It's come with damaging consequences in other parts of the world. And I think for a very long time, we will be chasing the ripples of this era on the mental health impacts, on child development, on society for a time to come. So it's really important that we take the lessons of what we have learnt in the pandemic and we make good of them, and we make sure that we address this in the future, because this is not our last pandemic.
I think this is a very relevant message. I mean, that indeed health of all individuals is relevant, but health of women is very relevant for many reasons, and also because they carry children into the world. So if there is any problem in delivery, in birth, or even in the very first months when you still are learning how to give milk to your baby, or any other problem that may arise, you don't have maybe the right access to health. This also just influences and impacts in the future. So as you say, the ripples or the waves, I would say, of what is happening now, they will reach the shore later on. I think that is also a question of education. It's not only about, indeed, socioeconomical status is relevant. I mean, you have money or you don't have money, they give you access or not, but also education is very relevant. And I think that now in Nature, I think it was two weeks ago or something like this, there was several articles on poverty and education, on equity in the access to health. And they were talking about tuberculosis, actually, as an example, as a paradigm of what could happen if it's a perfect storm between poverty and lack of education, and maybe not access to health, because I think that tuberculosis is a disease that has cure if it's really dealt with. So Siwi, what is your experience in Indonesia? Because I think that is relevant too.
Yes, yes. In the case of TB, as I said before, sometimes women they are not prioritizing themselves to get treatment because of the domestic responsibilities. Not that they don't have decision making, they don't have a decision, but they happily to put their effort for domestic, especially this is in rural area, since I have study on that, to seek proper treatment or proper management. So there is a delay for women to get the treatment, and this is seen as what you call normal for the family to have the woman especially taking care of their family first rather than their health. Yeah. So even though they already have symptoms, for instance, when we ask about whether they don't have transport or they don't have money to pay for the treatment, because now in Indonesia is actually with universal health coverage very easy for them. but it is not about that, yeah, but it's about putting the family responsibility first. And they, yes, they have information from the, yeah, so many sources, yeah, but what you call it, the information about TB itself is not so many, yeah. And then also, even though we, especially in Indonesia, we have around yearly around 500,000 TB cases, yeah. But women sometimes delay in the treatment, yeah, like that. So that's what I found recently in the study on gender and TB. Yeah.
So, yes, I think that everywhere in the world, I mean, indeed, we have to be very much aware of this effect on gender issues, even in our Western countries. Lydia, you have studied the effect of the COVID pandemics onto our gender roles and also gender, well, the gender gap in the access to health too. So what can you tell us from what your analysis on what has happened during these last 2 years?
Thank you, Gemma. Yes, on our study on COVID and gender, we identify different levels of analysis that is related to the analysis of gender and health in general. On the one hand, there are the first level of sex difference in terms of the health and the impact of a disease. That is the sex difference that, you know, we have a long tradition of in Europe with the Charité in Berlin, in Germany, that they start to identify how the symptoms of a disease, the treatment for a disease is different in terms of the hormones and all of the biological and genetics difference between women and men. And I think it's important, but it's a field related to medicine. But in the COVID-19, this is an infectious disease in which the social interaction is the main way of transmission, it's important also to take into account these social norms and the social structure and how, you know, it's important to these spaces of the dialogue and, you know, to have a common research between medicine and social science. And I think it's important to identify and prevent, you know, the transmission of COVID-19, but also with other infectious disease in which social interaction is important. And here we provide different analysis on the first in the first term, how the social division of labor affects the exposure to the disease, in terms of gender. And the result is related also with previous research, for example, in Ebola, that also the inequalities and the social space is different from gender, and also the level of education, the vertical segregation. It's important to identify the key factors to the transmission of the disease. And here we have, with the COVID-19, another measure that it's important to take into account. Is a political measure. It's related to the lockdown. Here in Spain, the lockdown affects to all people, but we have, and I think in the world, but here there are some essential jobs that they have to go to work, and they had exposed to the disease. But if we analyze what kind of essential jobs were identified, and we analyze this from a gender perspective, we identify that the sexual segregation of jobs, for example, women are the social group that they are working with the jobs related to the social interaction, in which social interaction is important. And I refer mainly to the care sector. Now, this care sector, it was an essential work for us, and the care sector implies this social interaction and very close interaction for also the quality of jobs. And I think it's important to take into account this, because this close social relation in care sector expose more workers from these professions at a difference, for example, with other essential profession here in Spain, like transport or manufacturing. Transport and manufacturing are basic occupied by men, no, the job positions, and these factoring and transport, this type of jobs, the social interaction are very low, and then the exposure to a disease, it's also low. And I think it's also important to take into account the different exposition of the disease. This is one issue that is related to social structure, but we find here another issue that it is related, as Hannah and Rena say, to gender norms, no, in terms of how gender roles, when we interiorize this, makes that women and men do different things in the society. For example, in the lockdown here in Spain, men were the responsible to go to the street to buy foods and the main needs for the family. And it related of this role of men that they have to provide security, and this related also to the male breadwinner, in terms of the subjectivity, I have to protect my family. And women were taking care of children inside the house. And this is also related to the feeling of vulnerability. And I think it's very famous, this feeling of vulnerability. And I think it's important also to take into account the balance between the exposition in the private life of men who goes outside to the public sphere, that it's the sphere of men, to buy foods, and the private sphere, the family sphere, that is a realm of women. And I think it's also important to take into account the different exposures by gender.
Well, thank you. I think it's a bit more complicated than this, because even in educated people in Western countries with the pandemics, I mean, young women had to be the ones that tended to the children and could not really work on their own jobs at home, because indeed you cannot be in front of the computer, do whatever, and at the same time take care of your kids. So I think that everyone, we are a scientist, many of us, and all of us know that that is before pandemics and after pandemics. During these 2 years, many different women, even if they had a career, a professional career at home, they could not really comply with their jobs because they had to take care of the kids. And there were the 2 of them at home, but okay, this is the role of females, and probably because they felt more like, I have to be with my kid that has 3 years old or 5 years old or 8 years old, they have to do homework. And even if you have right access to education and to internet or whatever, I mean, we have to be aware that in a, let's say, a stressful condition like pandemics, people tend to go back to the cultural reference or whatever, because they feel more comfortable. I don't know exactly why. I'm not a specialist on that. It's just I'm saying what I saw. And what I saw is that they tended to go back to very specific kind of roles, even when they were not told to. Let's say it was like voluntary. I mean, they took the role like it was the role they were expected to do. And I think, okay, this is something that happened in all cultures in one way or another. It doesn't matter if you're poor or you're rich or if you are educated or not. Maybe indeed the impact is more different, but the type of roles are quite similar. But maybe we have to move on to how to find let's say, equal access to health. And let's think about if e-health could be a means so that in society in general, there is more equity in health, not even on gender, just only because there is poverty, because there are many different regions around the world in which inequity is really relevant, apart from, so on top of the gender gap and the gender inequity. So, so Edward, would you like to talk about e-health in Uganda and in Africa in general? Do you think this would be a means so that people could have access to better health?
I think it's definitely a means of providing better access to health, or at least reducing the cost of reaching the individuals spread across the country. In sub-Saharan Africa, the future is not, it is not equally spread out. We have societies that seem more reflective of the 1920s than the 2020s. And we have the ranges all in between as you move from the smallholder subsistence farming households to the sort of urban settings in the cities. But with all of that, there is a real, you bring a lot of power onto the table when you engage e-health. And this can bring a lot of things to light that you weren't expecting. I think one of the problems we tend to have compared to the way we do our investments, both the government investments and the donor investments, they tend to be skewed somewhat depending on what the ease of implementation is. There is a tendency to try out your schemes, your risky e-health schemes that could have dramatic effects in sort of easier or more, or places with more infrastructure investment. And you end up leaving out some of the more needy areas just because they are difficult. There are also issues of language, because e-health and software development, essentially the dominant language of software development is English. But the same thing happens here with the content in e-health. The homogenization to English or to whatever dominant language you wish to proceed in. It becomes more difficult when it reaches out to the more rural communities. You need to take the time to contextualize it for them, do the localization, and also particularly having health workers as intermediaries in transmitting this helps a lot because they know how to adjust to the context in which they physically live. I think those are some of the big things we really note here in Africa.
I think that you have just pinpointed one very relevant thing, and is that you need a context on different places. So it's not the same if you are in a rural setting with certain needs and some way to explain how they feel or how their body is really feeling. I mean, you have to talk the same language so that you can, and I'm not just only talking about the language, but the same language in context too, so that you can really arrive to the people that you try to take care of. So I think that is relevant if we wish to talk about e-health in the future. It's not going to be one single e-health. There's going to be many different people in between that have to be intermediaries. I think this is the right word to do it. I am also, even if you have access to all of this, I still am worried about e-health, and I don't know if Hannah, maybe we can help us, but maybe we are not feeling that confident to talk into a screen of how we are feeling. So if you are talking to the medical doctor or the nurse or midwife, and they ask you, how do you feel? There are two types of people. When some people say, oh, I'm feeling bad and whatever. But most of the people will say, well, not bad. They're not really telling you how they feel, and they don't tell you the symptoms because they don't feel confident, because maybe there is something missing, like empathy or the look into the face. And I think that particularly in pregnant women or in young women with kids or in gynecology in general, I mean, I don't know if this works that well. So what is your experience with e-health, telehealth during the pandemics there in Australia? And what do you think, if you could tell us the strengths and weaknesses, or how we can improve that?
Yes, so in the birth and time of COVID study, we've been examining many things, and we've been examining models of care, we've been examining the use of telehealth. And in a nutshell, telehealth's both a blessing and a curse. I find it really fascinating. Doctors like telehealth more than midwives. I think that says a little bit about some of the gendered issues as well around telehealth. The majority of midwives are women. And about 50% of the medical professionals are male. So let's start with the positives. Let's start with the blessing part. When I think about life during the Spanish flu pandemic, there would have been no mobile phones, there would have been no social media, there'd be no Zoom to connect us. But on the other hand, many more people lived together in households. Life was more connected on that level of family and community than it is today. So in some senses today, we have greater access to technology and less access to human connection. We published a paper a few weeks ago, which was looking at the positives of the pandemic. It was called Never Let a Good Crisis Go to Waste, Positives from Disrupted Maternity Care in Australia. We asked women and midwives in surveys, and over 6,000 women have been involved in these surveys. Was there anything positive about the pandemic? So it was the last question in the survey, and I'm so glad I added it. Is there anything positive we should take forward? Because there's a lot of negative about COVID, let's face it. And having access to telehealth was seen as a positive by women and midwives. Having midwifery continuity of care models, having giving birth at home, and having a partner work from home was also very much seen as positives. And if you then looked at what did they say was positive about telehealth, they talked about it being more convenient, easier to access for women in remote settings. And of course, Australia is a very giant, I mean, we are pretty much the size of Europe, and we have deserts, and we have, many hundreds of kilometers between communities. So the remote settings, better issues for women, where women felt sometimes they go to appointments and they wait for somebody, and they get 5 minutes, and it's a waste, and they've paid for parking, and they've had to get childcare. So they found that it was more accessible, particularly if women had other children. And women would say things like, it's great as an option, but it should be a choice, not a mandate. So it was not always seen as positive. So in another paper that we're just about to send for publication, we looked at telehealth, and it's called A Lot of Bad, Some Good, and Possibility. And in that, we asked women about their telehealth experiences, and they found, and the responses that women gave were that telehealth was inconsistent. It ranged from a telephone call to video conferencing. So when we talk about telehealth, if you Google telehealth on the internet, you have the doctor or the nurse reaching through the screen. It's face to face, it's very connected looking, but often it's a hurried phone call. That's the reality. Both women and midwives noted that there were benefits like reducing the risk of COVID transmission, more flexibility, convenience, cost, etc. But many women felt let down with telehealth. They felt it was unsuitable for clinical assessment. They felt it was really unsuitable for psychological and psychosocial assessment. Midwives told us they stopped asking the questions about mental health and domestic violence and sexual abuse, etc., because they didn't know who was listening. And they talked to us about several cases where they felt that because of that, big important things were missed that had an impact. midwives found massive technological challenges. They found that often they didn't work, that the equipment was really old, that there was such a lot of variation in the quality of telehealth. And one of the big things that women said is, it is not a substitute for face-to-face. It's a great adjunct, but we still want contact. We still want to see our midwives. We still want human connection and human touch. Another interesting thing that women said to us was midwives are different when they're on telehealth to when they're there in person. And it's all the micro language, isn't it? What women said is, when I go to see my midwife face to face, she'll ask me how my day's been, how my week's been, how am I going, how am I feeling? But when you're on a phone and you're disconnected from the person, what we would say in Australia is they cut to the chase. So they will go, how's your baby moving? You know, have you done this? And it was very factual. So the micro communication structure is very different on telehealth. And I think that we need to be really mindful. And I worry, because I now hear services, maternity services, saying, when the pandemic's over, we should just continue because it's so convenient for us. And I think maternity services say we could save money, we could save cars, having to go out and see women postnatally, we could save parking difficulties, we could save busy clinics. It's all going to be so convenient for us. But women are telling us, we want the choice, a bit of it's good, but we do not want it forced onto us, and we do not want it to take the place of human connection, which still is fundamentally really important to us.
Yeah, I also agree with you that it's not a substitution. It should be just something that is very helpful, that in many times it could even ease the queue of people wanting to go to the nurse or the medical doctor or the midwife. But indeed, probably it's still far apart from being a substitution, because we are human beings, and human beings like to be in touch. And that's something that probably is difficult to substitute. I think we can move now onwards and go to the questions that just the audience posed. And I think I'm just looking at them, and many of them have already been directed to some of you. So I think we can stretch at least for nearly 1/4 of an hour of questions from the audience. So there is a question for Lydia. I'm sorry if I don't pronounce well the name. I think it's Daniel Kwakie Noma. And he says, oh, thank you, Lydia, for your vital insights. I think that regarding the study on access to health information among women, did you stratify according to the country of origin, so if they were migrants or non-migrants? And if you did, if it was the same, irrespective of their status and of the country of origin?
Mm-hmm. Thank you very much for the question. In the qualitative study, we identify the migrants and non-migrants, and we look for sample for migrants too. And they were all women in this study, the qualitative study. And we identify that the migrant people have looked for health information, but it's interesting that here, again, the level of studies, it was key, because when the migrant people works in the care sector, and here in Spain, there are an important percentage of migrant women who works in the care sector, and then they look for information of health on the internet. It was important. But I think it's also important the issue of how they identify the confidence of this information. No, and I identify that when they are working as care workers, they identify more the confidence in terms of the source of the information than, for example, the women who are not working in the care sector and look for information in terms of health. These women from the social class, the low level of social class, and don't identify the source. No, they identify the feeling and not the internal emotions of the information. And I think it's an important difference. And in terms of the quantitative data, when we identify migrants and non-migrants, we identify a very worrying data, that is that migrant people look less information on health issues than non-migrant people in Europe. No? These are data from Eurostat. And I think it's very worrying, and we have to identify why the migrant people don't use internet for looking for health issue in regarding the non-migrant people. I think it's an interesting issue to look into why.
Thank you. There is also another question for Hannah. It's from Maria Villalobos, and she said that she finds quite interesting the question of the appropriate inclusion of women in medical trials. This is an issue that, just like Hannah said, we have been struggling since the beginning of modern medicine. It is frustrating that you see that issue shining again with the same strength during the pandemics. There has been, of course, several initiatives that address this, but I would not call it the mainstream approach. I'm curious about your opinion. Why have not been able to exercise this issue or to excise this issue from the development of drugs, and how we can do it structurally better in the future? I think it's a question for Hannah, and also maybe for someone of you. Hannah, if you wish to start with.
Yeah, it's a really good question, and we are just about to publish a paper looking at vaccines and the uptake by pregnant women and what women say about their concerns around vaccines. And we do it all the time. So many drugs are given to pregnant women that have actually not been properly trialed. Pregnant women are often excluded. In fact, most of the first line drug trials involve healthy young, usually males. I mean, much of research focuses on the healthy young male in drug trials. So it's a massive problem. We also know women are more vaccine hesitant, and women are more vaccine hesitant because they give birth, because they have ovum, because they care about and are worried about the impact on their babies. So we've got to get better at including women in trials. The other thing, it's not just about including them in trials. I know Pfizer now has a trial ongoing for pregnant women, but it's also about gathering data. So I can't tell you, other than our survey, what percentage of Australian women who are pregnant have been vaccinated. We can tell you what percentage of the population have been vaccinated, but not the pregnant women. And then that is really, really concerning. And the other thing is that in the research that we've been doing is it's the lower socioeconomic, it's people from lower education backgrounds, it's people who have less income. They're the more likely to be vaccine hesitant. So we have to include pregnant women in trials, obviously carefully and with thought and with good follow-up. But we also have to look at how information of health information around things like vaccinations are perceived, received, understood, and then taken up by different groups within our society. And we need a vaccine register for pregnant women, where we're lobbying for it in Australia, because we have several vaccines now given to pregnant women. We're probably going to have a DBS vaccine next. We're going to have a respiratory a virus vaccine after that. We need to start now collecting good data, and we need to look at long-term effects, because women then say to us, well, how do I know it's safe? And the honest answer is, we don't. We just know that doing this in the pandemic is safer than not doing it. So we've got a long way to go on this issue.
Thank you. Yeah, I think we can also ask Siwi. Siwi, I mean, about your concern on the cultural issues that really apply to women. How do you envision that we could do with that in the future? How we can revert this, even if it takes a long while? Because I know that culture is something that is embedded, is ingrained in ourselves because we have been educated in this society. How can we change this? How can we make women more empowered in a way, even if it's not changing society, just to change society?
Yeah, thank you very much for the questions. So, yeah, as you know, Indonesia is a very big country with so many population, more than 267 million, and many languages, many culture. Yeah. I think using technology is, I mean, there is an opportunity to use technology, especially right now because of the pandemic. Then people actually are forced to use the technology, yeah, or it is not forced, not happily, but they are also actually more, I mean, spend more time, yeah, to access technology. But the thing is about the kind of information that we give to them, yeah, especially how to systematically or especially putting the health information that is really truth, yeah, truthful information, because so many information are actually misleading. Yeah, people are actually would like only to get the information that is easy to do, and then sometimes it's not scientifically based. Yeah, and also is, yeah, especially easy to do, and then they tend to actually use the technology and as also, I mean, use the information, but they don't know whether this is actually true information. So I think we need to what we call it, have a massive education and information that is true information, and also especially not only educating women to be assertive, yeah, but also educating men to be balanced, yeah, and not only comfortable with the situation, but also what you call it, stimulating with the quality of the information should make the man can also see the burden of the woman, like that. So for instance, in this is culturally actually determined already. In the elementary school, for instance, what the subject of Indonesian language, for instance, is always saying that mom's going to the market and cook, yeah, at the house, yeah, domestic work, but father go to the office, for instance. So this should be balanced. I mean, the men should be educated for not doing like that, yeah. So more, I would expect that more, for instance, men cook and then also helping the wife cook, or also change the diaper, should be in the what you call it, in the advertisement, massive advertisement. Yeah, so from the elementary school up to the higher education, yeah. So if there is no massive information like that, that is systematic and then structured and massive like that, then it's very difficult to change because it's already embedded in the culture. And sorry to say that men already very comfortable with that. Yeah. So So that's using technology can be very helpful, and also many advantages of that. Yeah.
There is another small question for you before moving to Edward. I mean, Sarah Callis asks, she's worried about children, especially those under age 5, to develop tuberculosis. And she's asking what we can do as a general practitioner to prevent or achieve success for TB in children, especially about women mother encouragement. I mean, if you can just give a short answer, and then we move to the last question to Edward, and then we close.
Yes,
Please,
actually the prophylaxis for TB, or for children that the mother or father had TB is started, but it is also we had actually research on that long time ago, I think, but now it's tend to be also repeated. People still see that the children, they are not having TB yet. So prophylaxis is not useful, or because they said that drugs is also poison, like that. So we have to give the awareness of the parents that when they have TB, then most likely that their children under 5 can get TB too, transmitted by that. So I think this is also the education for that, especially, and then also especially the health system, yeah, should actually, for instance, if they already have the program, then the availability, the health system actually should work together to what you call it, to make that successful, like that. Yeah. So in a way, education, but also family education, but also health system delivery. Yeah.
Thanks. So Edward, about e-health in Africa, do you think this is going to be implemented all over, and who is going to be in charge of that? It's going to be like health system, public health system, or it's going to be like, let's say, outsourced to private companies? What do you think of that?
Ideally, you would have the stewards of the public health space, the ministries of health, being the ones driving e-health. Unfortunately, they have to operate at scale. The Ministry of Health doesn't get the option of doing a small project in one area of the country in case they get accused of favoritism. So in many cases, the actual frontier leaders are going to be smaller private organizations, either donor funded or privately funded. We've had a significant case in Uganda where the case for telemedicine had continuously been advocated, but no one had taken major steps forward until a private company set up for commercial purposes pushed this. And when the pandemic hit, that suddenly came to the forefront of everybody's mind. But the inability of the Ministry of Health to do this for the whole country at the same time constrained them significantly. We hope that these responsibilities can be transitioned to the ministries of health. But in Africa, sub-Saharan Africa particularly, one of the big problems is, one, the per capita health spend and the lack of universal health care and health insurance. This means that a lot of health decisions are made based on cost when they shouldn't have to be. And this implies that whenever the one thing we're really lacking is health investment, I think, is the biggest factor. we can make strides forward in other areas, but unless the health investment comes in to backfill, we only get limited success. Thank you.
I agree with you that ideally it should be something public. I'm a very strong advocate for public health, but I understand all the points that you have just put on the table, and they are relevant indeed, and this is food for thought. I agree with you. So I think that we are approaching just the ending, and what I would like to propose you is that you can, all of you, I'm going to give the word, just that you can provide a take-home message, like 1 minute, something to be a briefing resume of what you've said. So just an idea or something, a message that you wish to convey to the audience, just to close this session. So I'm going to start with Lydia. Please, can you start with your take-home message?
Okay, thank you, Gemma. My main message is about how gender inequalities affects to the health of women. And then it's important to tackle gender inequalities to prevent the disease in women in several issues. On the one hand, in terms of the sex difference, it's important that the medicines study the sex difference in terms of the disease, the treatments, the drugs, and also with an intersectional approach, not only women and men, but also the transgender people, the effects also in terms of the race, in terms of the age, in terms of the different intersection that could affect the identification and the treatments of disease. And on the other hand, how the gender norms that we interiorize when we are a child affects also the exposition to disease, and also it's important in terms of women and in relation of all the work that women have in terms of the care work and the working outside in the labor market. I think it's important to prevent of gender inequalities, to prevent the illness related to these social inequalities.
Thank you, Lydia. Now, Hannah, if you wish to provide your take-home message, your last message today.
Thank you. As I said earlier on, I think women have been left holding the baby during the pandemic, and I think it's come with deadly and damaging consequences. And I do think we will be chasing the ripples of this time in mental health impacts, in child development, and in families for a while. I think we absolutely owe it to women and babies and families to learn the lessons of this time, and we need to learn them and do better next time, because there will be a next time. I think as our planet warms, there will be many more next times to come. In Australia, we often are considered the bellwether of the world, but we've had devastating fires, floods, and a pandemic in the last 2.5 years. And we need to understand the models of care that protect. We need to understand the electronic mediums that are best to connect during these times. We need to understand who benefits, who does not. And these are all questions that I think need urgent answering. I think the COVID pandemic has shown us that we actually still don't truly value women. I think we have forgotten that the hand that rocks the cradle is so powerful, that the child that steps from the cradle is a product of that hand, and we need to value women if we value the future of our society. I think we have a harsher and harder world to live in the future. I think we also have in our hands the best technology, and we need to learn how to use it wisely. We need to learn how to use it to its full capacity, but we must never forget that human touch and social connection are still the most powerful force on earth in shaping both social identity, mental health, and the human race. And while telehealth has a place in post-pandemic maternity care, it's important that the evidence of the benefit rather than economics drives care delivery. I really am concerned about the voice of economics over the quality of care. And I think COVID has taught us some very valuable lessons. It's taught us little things matter, because in fact, those little things are the big things in life. And I have 3 words at the bottom of my diary of deadlines that I look at every day, and they are survive, thrive, and transform. And they come from the global strategy for women's and children's and adolescent health. And I think it's time for us now to get back beyond surviving to thriving and to transforming. And as health providers, we need to be at the forefront of making sure our communities do thrive and are able to transform in the future.
Thank you for your insights. Also, Siwi, your message today, your last message.
Thank you very much. I'll be being optimistic. Yeah, I believe there is no steady and linear culture. Now the time to change is now, actually, even though it is, can be difficult, and it should be planned, and technically we have to the technology to do that, as I said before. So to give an example, for instance, using the government provided platform of Peduli Lindungi, that's the literally translated as caring and protecting, where the informations by the government is actually there, and also the vaccine status of the people in Indonesia, especially because this platform already accessed by around 90 million. So I think I'm optimistic and positive that we can little by little maybe change the culture that is actually not so benefited to us, especially in terms of equity. Thank you very much.
Thank you. So, Eduard, it's your time now to give this message to all the audience, please.
Yes, I think my take home is that digital health initiatives, all the way from telehealth on one side to simple health access messaging, can have a huge impact on health access, both increasing the opportunity and reducing the cost of health access, and therefore addressing the issues of equity. I think, though, it is important to remember that digital health tools are just amplifiers for the base of our health system. We should not forget to invest in the basics of our health system, the investment per patient, the investments in the infrastructure, and also addressing the issues of buy-in and adoption by the ministries, who are eventually going to be the long-term carriers of these initiatives. Thank you.
Well, thank you to all of you. I think that you have provided all of us with lots of reflections and food for thought for all of us. It has been amazing to be the moderator of this session. I come back with many ideas that I wish to think about. Thank you for being here. I think that all of us, we are realizing that the world is global, and that the pandemics even just made it just really transparent to all of us, that we have to work together towards trying to get a world where there is access to health, e-health or whatever, but we have to have all of us access to reduce inequities, and also to help women to find, at least to claim the right place in the world. But it's not just only on women, it's just about all society. So thank you, all of you. And I'm just giving thanks also to the UOC for being host. And I'm going to introduce now Marta Imeric, who is the Vice President for Strategic Planning and Research at UOC, who is the host of this act. So Marta, the floor is yours so that you can close the session properly.
Thank you. Thank you very much. It's really a great honor for me to close this AIU webinar on exploring nexus between health, equity, and gender. And we really feel so proud. It has been a real pleasure to be with you today. We feel so proud of co-hosting with the AIU, the organization of this thoughtful event. First and foremost, I would like to express my appreciation to the panelists for their valuable contribution to the webinar. Thank you very much, Gemma Marfany, for this excellent job in moderating this session, for being a great chairwoman, animating and linking one talk to another. Thank you very much, Siwi, Lydia, Edward, and Hannah, for your really inspiring and thought-provoking words, really, and about this diversity of issues regarding health, equity, and gender, and as well as how e-health can have a contribution to it. We learned that gender equality matters for health. Definitely, it matters. It is one of the most important drivers of health and health inequalities of our time. We learned that. And beyond quantitative gender equality, we must strive for a cultural transformation that allows us avoiding conscious as well as unconscious gender biases in healthcare for everyone, everywhere. We also learn that gender inequality is transformed into health risk through discriminatory values, norms, beliefs, and practices, differential exposures and susceptibilities to disease, disability, and injuries, biases in health systems, and biases in health research. We have been seeing several examples today. Finally, panelists brought us to learn that e-health, if it is people-centered, can help to diminish some of these risk factors. Although we must have a close look to digital health regarding its evidence of benefit, social and health benefit, not just economic benefit. We must follow how it is applied in order not to enlarge inequalities in health, including the ones caused by gender biases. So the work is really pleased to lead the SDG cluster, SDG 3 cluster, and we assume with great responsibility this AIU endeavor. The cluster, as the General Secretary Hiliji Van Lan mentioned, it has 7 active members across the globe. Makerere University in Uganda, Universidad de Caldas in Colombia, Gadjah Mada in Indonesia, West Sydney University in Australia, Karolinska Institutet in Sweden, and University College in Dublin in Ireland. So thank you very much for all of that. Thank you all for your generosity to share all your valuable work in this webinar. And thank you very much, attendees from all over the world. I'm happy to say that from all over the world. Your questions definitely enriched the webinar. So this webinar, it is for sure, was really a success, and we are going to spread your words as far and wide we can. The UOC, the Open University of Catalonia, is grateful to all of you. Thank you very much.
Probably we can leave now.
Thank you very much.